Uh, I I am extremely grateful for every one of you, each of you taking the time today to be here for something really important and an incredibly challenging landscape for all of us as clinicians to navigate, which is how to really interpret the divergent federal and state practice guidelines in our vaccine practices. And I am really honored today to have an incredible panel of speakers. For those who do not know me and haven't attended our PHACT before, I'm Aarti Barnes, the Chief Medical Officer at the Illinois Department of Public Health. And with me are Dr. Jennifer Suh, who will be speaking to us about some really important clinical aspects of this presentation. Dr. Suh is our pediatric medical advisor. She's dual boarded in internal medicine and pediatrics. And prior to joining IDPH, served as the chief medical officer of Christian Community Health Center and FQHC. And prior to that was the chief medical officer at the Chicago Department of Public Health, where she really oversaw a lot of strategy around healthcare access integration and direct services, clinical services provided by public health systems. And in addition, she also has her law degree from Columbia and a fellowship in clinical medical ethics. So incredibly privileged to have her really talk to us today about some of these implications. And joining her is Matt Pickett. Matt is from our Illinois Department of Insurance. He has over 2 decades of congressional, state senator, and state legislative experience, as well as really having been critically important in driving some of the legislation in the state around the state regulated marketplaces, as well as pharmacy PBMs. And we appreciate Matt. He is the senior policy advisor and health coordinator at the Department of Insurance. So appreciate both their presence today, and we expect that they will really help guide us in our understanding of what needs to come next in our clinical practice. So we do offer CME. There will be a survey that is live for about 7 days after the presentation, and you are required to answer the questions on the survey to be able to receive CME. If you do not require CME, please check with your licensing organization if the credit that you receive for participation is transferable for any CEUs. Among our panelists and our organizers, including David Hale Arroyo, our organizer today, we have no financial disclosures whatsoever. And we have also an incredible panel of team members to help us moderate today, with Wallace Dandridge, Julia Strelo, as well as Pat Montalvo, who will help moderate the session. A little bit of Q&A. Because of the size of the participants, live chat has been disabled. You will only be able to put your questions in the Q&A itself, and the moderators will be reviewing it. And specifically, I will call out if any questions needed to be answered live. We will be saving some of the live questions towards the end of the presentation. Just note, we are recording the session. Any other recorders or bots that are participants will be removed from the session. So this is really for live participants only. And as I mentioned previously, there will be a post-webinar survey that will be available. What we want to focus today is really understanding the differences, the variance between federal professional medical society and state immunization schedules, and trying to identify strategies on how best to communicate that variance to our patients, who I am sure are struggling with understanding what needs to be done next, and doing a deeper dive finally in the real impact of insurance coverage and access, not just our guidance. And so leading us on our path to enlightenment, I am going to turn it over to Dr. Suh, who is going to take us away here.
Thank you so much, Dr. Barnes. And thank you to all of you for joining us today. All right. So this has been, it seems like a long road coming, but We have been preparing for this moment. I mean, even before the last year, but just to review what happened over 2025, a lot happened. And thank you for all of you for following along with us and partnering with us to make sure that Illinoisans continue to have access to critical vaccines. But, in the early months of 2025, in the spring, IDPH, along with our local health departments, with many of you in healthcare, other state agencies, we were responding to measles cases. And as you all know, measles is still here in the United States, in our state as well. And so we really worked together to think of a way that we could strategically make sure that vaccines were still available and that those who may not have had access before to vaccines had them through, for example, mobile vaccinations and partnering with our local health departments. As you all know, in the late spring, early summer, there were several changes at the federal level. The federal administration announced vaccine changes without ACIP, Advisory Committee on Immunization Practice Review or recommendation. They rapidly reconstituted the ACIP. And so during the summer, IDPH, we not only made sure to keep you informed through Dear Colleague letters and health advisories, but we also started to bolster our Immunization Advisory Committee. And I'll tell you a little bit more about that committee in a moment. So through the summer, we were waiting for COVID-19 vaccination recommendations from the ACIP, and we were anticipating reviewing other guidelines to evidence. In September, our governor issued an executive order, as you may know, to make sure that access, again, to critical vaccines were maintained here in Illinois. And IDPH led that execution of the executive order. We convened our Immunization Advisory Committee shortly after the ACIP met and changed COVID-19 vaccine recommendations. We issued a standing order, followed respiratory guidance, and then we made it clear which routine immunization schedules that we were endorsing, and those were the prior ones. We also began to work with our state partners, really continue to work with our state partners and our local health departments to make sure that there was plenty of access to flu, COVID-19, and RSV immunizations. This included providing support to our local health departments and also mobile vaccinations. So continuing the work that we started in the spring. And then in December, Governor Pritzker, again, signed into law a statute that further empowered IDPH. And I'll tell you a little bit more about what that law did, but in terms of insurance access, coverage to vaccines, and then also really strengthened our Immunization Advisory Committee so that we here at the state level could make sure, again, to protect that access to critical vaccines. And then when the ACIP changed the hepatitis B vaccination recommendation at birth to shared clinical decision making for those who were born to mothers who were hepatitis B negative, we made sure that we convened our Immunization Advisory Committee, reviewed the evidence, and issued guidance maintaining universal hepatitis B vaccination recommendations at birth. So again, a lot happened in 2025. So then here we are in 2026, and fresh off of the new year, the federal administration announced changes to the childhood vaccine schedule. This was without another convening of the ACIP, without an additional evidence review. And we shortly afterwards just reaffirmed to all of you clinicians that we were not changing our recommendation for the childhood immunization schedule. So we were staying the same based on the evidence that we had. So what were these changes at the federal level? Again, this was an announcement without the usual convening of the ACIP. So this chart is just showing what the updated federal recommendations are. And I just wanted to highlight a few of them. One, RSV. It was very confusing for many clinicians because they moved it into this category called for certain high-risk groups or populations. At the end of the day, that recommendation actually did not change. So any child under the age of 8 months whose mother did not receive vaccination or didn't receive it in time during pregnancy should be getting the RSV immunization. So just wanted to point that out. Despite kind of moving it around into a different category, the recommendation actually is unchanged. The HPV vaccine. Great news, it was continued as a universal recommendation, but the recommendation was changed to a 1-dose series at age 11 to 12 years. Now, there is an ongoing evidence review that is happening with our partners at the Vaccine Integrity Project. We've also been reviewing the data. They're, just acknowledging globally, there are other countries who do a 1-dose schedule. There is some evidence that it could be effective, but we need to make sure that that evidence applies to our situation here in the United States with our schedule. How does it impact cancers beyond just cervical cancer? So again, that evidence review is happening. Now, there were several vaccines that were universally recommended at certain age groups that were moved into this shared clinical decision-making bucket. And I just wanted to point out, so again, the ACIP had already previously met and changed recommendations to COVID-19 and the hepatitis B vaccines. But with this recent announcement at the beginning of January, the CDC also said that they were moving rotavirus, influenza, hepatitis B, and then the meningococcal ACWY vaccines to shared clinical decision-making recommendation. Again, this happened without the usual ACIP review process and without new evidence to support the change. At the end of January, the AAP also, as they always do, released their own childhood immunization schedule. And this was a schedule that made no changes essentially to what had been recommended previously. They maintained the current recommendations for universal vaccination of those vaccines that I mentioned had been moved to shared clinical decision making. And I think it's very, very important to note that 12 large major medical and health organizations endorsed these recommendations. They agreed that the evidence showed that the schedule should be kept the same. Just a little bit about the history of U.S. childhood immunization schedule development. So in the 1930s, that's actually when the AAP, the American Academy of Pediatrics, was established. Actually, in 1938, they published the first version of the Red Book. And many of you may know that the Red Book really is the go-to guide for those of us in pediatric practice and public health on how to prevent infections and how to treat infections. In that Red Book, they included guidance on vaccines, on the vaccines that were available at that time. And then through the years, they continued to provide guidance on the schedule and the number of doses and whatnot of the vaccines. However, they recognized, along with the federal government, the American Public Health Association, and other groups, that there needed to be a more formal process for developing vaccine guidance. So that was when, in 1964, the CDC's Advisory Committee on Immunization Practices, or ACIP, was created. And so, along all those years, the AAP and other professional medical societies, they were following along with ACIP as liaisons and working with the CDC experts. But there was still a separate schedule that was being issued between AAP and CDC. But in early 1993, the two groups committed and pledged to create one schedule, because as you all know, it is very confusing when there are multiple different schedules to have to try to go through. And then in 1995, the first harmonized schedule was released. So AAP and CDC. And if you look at prior versions of the CDC schedules, you will see that the AAP has endorsed it, that the AAFP, and they're the same schedules, right? But with all of the changes that recently happened in 2025, for the first time in 30 years, the AAP had to release a schedule that wasn't harmonized with the CDC. Just wanted to let you all know that, who issues the Red Book, who issues infectious disease guidance for the American Academy of Pediatrics. They have their own committee on infectious diseases, 16 members, infectious disease specialists. There are other experts that work on the policies, liaisons from other specialty groups. They not only were previously part of ACIP work groups, so privy and part of conversations about the evidence and about the best recommendations for United States children, but also, they, just like the ACIP should be doing, they review vaccine safety, vaccine efficacy and effectiveness, the epidemiology, real world impact of disease. So just to remind that the schedule that comes out from the AAP is actually an evidence-based process that has been going on for many, many years. Now, here in Illinois, we also have an immunization advisory committee. And as I said, over the summer, we worked to bolster it. And with the new law, their strength and their ability to give us recommendations was really solidified. So currently we have 20 members. They're tasked with providing credible, transparent, evidence-informed, science-based recommendations to our IDPH director. So really helping us bring in their expertise and data review and their real-world experience working with patients to provide recommendations to IDPH for Illinois and specifically. We have experts across the board. You can see the breadth of specialties and expertise, and we convened them again in early February to review the childhood immunization schedules and to give us recommendations on which schedule we should go with. And they recommended that we should endorse the American Academy of Pediatrics schedule. And we agreed. And so the next day we announced that we were endorsing officially the American Academy of Pediatrics childhood vaccination schedule. So, what does this all mean? The good news for clinicians is that means the guidance is unchanged. You should continue doing what you were doing. The schedule is unchanged. And you will see that on our immunization website, we have updated the links. We include links for more patient public facing schedules that you can share in your clinics, but also the AAP's schedule more for clinicians. That includes the catch-up schedule, special circumstances, etc. So no changes to the childhood immunization guidance. We've gotten a lot of questions about what this means for school and childcare immunization requirements. The answer is nothing has changed. Those requirements remain in place. Nothing has changed. Our guidance, our immunization schedule has not changed. The requirements for school and childcare have not changed. So guidance is one thing, but what about access to these vaccines? So a lot of questions here, and we are so pleased again to have our colleague from the Department of Insurance. But right now, insurance coverage also remains unchanged. Matt will go into more details on what this all means, but again, the law that was recently passed means that state-regulated insurance plans are required to cover immunizations recommended specifically by IDPH. And then in addition to those that our state may not regulate, vaccine recommendations, just remember that shared clinical decision-making recommendations are still recommendations from the CDC. And so they do trigger the Affordable Care Act's requirement to cover the vaccines without cost sharing. And the federal government itself also said that insurance coverage will not change for all immunizations recommended by the CDC as of December 31st of last year. And this includes Medicaid. So at this time, no changes. Now, if the ACIP were to change recommendations and fully not recommend a vaccine, that would have insurance implications. And we will, of course, make sure to reconvene and keep you all updated on that. The Vaccines for Children program, a very important program for Illinois children, for children across the United States. As many of you probably know, this is a program that provides free vaccines to ensure that cost is not a barrier to immunization for Medicaid eligible, uninsured, underinsured, or American Indian or Alaska Native children. So we've gotten a lot of questions about this too. At this time, the availability of vaccines through that program remains unchanged. One thing to keep in mind is that vaccines included in the VFC program, they don't change unless the ACIP makes a resolution to modify the coverage, and none of that happened. As I said, the ACIP did not convene before these new recommendations from the CDC came out in early January. But these vaccines being available through the Vaccines for Children program largely is one thing. The second thing is access really depends on when vaccine providers enrolling as VFC providers, and then VFC providers adequately stocking the vaccines. In case you ever need to find a VFC provider, we do have a vaccine locator on our website. But I just wanted to flag this. It is so important. We know that VFC providers, you all are doing a lot of work to make sure our children get vaccinated. But we've already seen challenges with, for example, the COVID vaccine not being stocked by all of our VFC providers because the federal government made that optional. We had a decline of more than 25% of VFC providers stocking the COVID-19 vaccines, which means that there's decreased access for our children. And that's also why we initiated the support to the local health departments and our mobile vaccination. But we really need our medical homes, our VFC providers, to make sure they're stocking all of these vaccines for our families. So at the end of the day, IDPH recommends that clinicians promote and offer all the immunizations to children according to the AAP schedule. This is our IDPH endorsed schedule. The evidence continues to support this schedule. Medical consensus continues to support this schedule. As I mentioned, 12 very large major professional medical and health organizations endorse this schedule, and that helps to establish a standard of care, right? Keep in mind, federal vaccine recommendations, they are not mandates. They don't in themselves establish a standard of care. You have all of these medical groups and the Illinois Department of Public Health saying the AAP schedule is the one to go with. So that is establishing a standard of care. The other thing that we've been hearing is, oh, the ACIP, the CDC no longer recommends those immunizations, that they changed the shared clinical decision-making. Shared clinical decision-making recommended vaccines are still recommended vaccines listed by the CDC. So please help us change that narrative. These are still recommended vaccines, and I'll go into a little bit of what exactly that means, that shared clinical decision-making. The other thing that we've been hearing are people are saying that the vaccines aren't covered under the vaccine injury compensation program, which is kind of a no fault. Like this is the pathway that individuals need to take if they want to file a claim because they had some kind of adverse effect from a vaccine. No changes to that vaccine program, that compensation program, because there are multiple different processes and steps that need to go into place before any changes can be made. So again, at the end of the day, patients and families, what they need from you all, they need your clinical expertise. You went through all of your nursing, medical, clinical, pharmacy training. We need your clinical expertise out there and strongly. We need your strong recommendations. And our patients and families, they need access to these immunizations through you. So please make sure you're continuing to stock and offer these vaccines. We're going to start with a little poll just to get a sense of where you all are. So David, if you could please make sure to release that poll. Just to get a sense of how you all are feeling about shared clinical decision making. And I'm gonna keep talking while you all are mulling over that. But I know that this is a lot, and you all may be thinking, easier said than done. Providing vaccines, providing recommendations, easier said than done. But I'm here to tell you that we trust you, the community trusts you, and we know that you can absolutely do this, and we depend on you. So these are a couple of polls that were done over the summer and the fall, and you can see consistently top trusted groups, individuals, their pediatricians, their physicians, their healthcare providers. So you are the most trusted people. People like me at a public health department, not as popular, not as trusted. So we really, really need your voices. Keep that in mind. The other thing that I think is important to keep in mind is that, again, there's this narrative of, oh, no one wants to get vaccinated. So the other thing I wanted you all to know is that community consensus also favors childhood vaccination. There's a lot. I know it feels daunting and that people are coming in and declining vaccinations, but just keep in mind, the vast majority of adults, the vast majority of parents, 80%, they still think that these recommendations should be kept in place, and in fact that they should be required, that these vaccines should continue to be required in schools. So again, community consensus, medical consensus, this is all in favor of childhood vaccinations. Okay, so shared clinical decision making. What does this all mean? This has caused a lot of confusion among clinicians, among the community. Don't be scared of shared clinical decision making. Here's why. Okay, for a routine universal recommendation, the default decision is to vaccinate. Again, like I said, shared clinical decision making does not mean that there is no recommendation to vaccinate. What it implies is that there's no default. The implication is that vaccinating and not vaccinating, that they're both medically reasonable options. And the decision can be informed by evidence of who may benefit, individual characteristics, your clinical judgment, and characteristics of the vaccine being considered. Now, typically, here's where it's become challenging. ACIP usually, when they make that decision to either recommend universally or recommend under shared clinical decision making, is through a very transparent process where they evaluate using the evidence to recommendation framework. Is it a problem of public health importance, the benefits and the harms, values of the population, acceptability, resource use, equity, feasibility. Again, very, very structured, but that hasn't happened here, and that's what's led to confusion because you all may be looking at the data and the evidence and you're like, really? It's medically reasonable to not vaccinate? And again, after review of all of the various guidelines and the data, our Immunization Advisory Committee, IDPH, the American Academy of Pediatrics, all of those other professional medical societies, they've continued universal vaccination recommendations because, in fact, the evidence does not show that vaccinating and not vaccinating are both medically reasonable options or that some may not benefit from the vaccine. Evidence shows that everyone would benefit from the vaccine. So, and I'm just here to confirm what you all may be feeling, right? The who may benefit, the fact that maybe not vaccinating is a reasonable option. It's really hard to say that when you see the numbers and you see the data, you see that vaccinations were effective. This is showing hepatitis B vaccination. So after universal vaccination began at birth in 1991, hepatitis B infections among U.S. children dropped by 99%. But you see cases are still happening. And so we know that protection still needs to happen. You all have likely seen patients who have suffered from vaccine preventable diseases. And so that's where the disconnect is. And that's why we've continued to recommend universally that all children at birth should get the hepatitis B vaccine. What I will note is if you do need a little bit more information on the rationale behind ACIP's former universal recommendations, when we send out the slides, we'll include an appendix with a little bit more information to so that you can have that information as you're having conversations with patients and with colleagues. And then again, with all these other vaccines that were downgraded to shared clinical decision making, again, you can see that like steep decline after vaccination. I'm sure many of you remember before the rotavirus vaccine that there were thousands, hundreds of thousands of children coming into the, clinics and hospitals with diarrhea, having to be hospitalized because something like Pedialyte actually doesn't work, that they needed the IV hydration, hepatitis A cases, again, this dramatic decline. We know that if an adult gets hepatitis A and they're not hospitalized, they're still out of work on average 2 weeks. And if they are over a month, like really big impacts, in addition to the damage to the liver and the jaundice and whatnot. And then for meningococcal disease, just remember, again, we're targeting teens because they're the highest carrier of asymptomatic carriers of meningococcal disease, primary group that's transmitting to other age groups. And again, we're still seeing cases and in fact an increase in meningococcal serogroup Y. So I think again, this is all just to affirm what you're feeling, but that the data shows that vaccination and universal recommendation for these vaccines still makes sense. The other thing I want to point out is, hepatitis A, when we had this spike in cases, 2016 to 2019, a lot of it was due to low adult vaccination coverage. And as a MedPeace physician, I'm here to remind all of us, kids become adults. So we want the kids to get vaccinated early on so their immune systems can learn and be prepared for whatever may come when they're adults. Okay, so just a reminder, I know that you all have likely heard this, but strategies for communicating with patients, because again, it can seem daunting in this environment. So this is actually a little acronym, a way to remember the various components. And just to highlight it, it's from the adult immunization standards. And we've been talking a lot about children, but adults, of course, we also need to be doing those strong vaccine recommendations. So, share tailored reasons why the vaccine is right for the patient who is in front of you. Make sure they understand that. Highlight positive experience with vaccines, and whether it's personal or something that you've experienced with other patients. Just, I think sometimes we assume that people will know these things, but I think, especially with all of the various types of information out there, we need to make sure our patients have the correct information and straight from you, our trusted messengers. Make sure you're addressing the patient questions and concerns. Again, you'll probably have to do a little bit more work now with everything going on. Start with empathy and listening, be relatable. These are all things that you know about. I thought this was interesting, address, don't repeat false information, because what we found is if you repeat that false information that a patient may tell you that they heard, it actually somehow reinforces it in their mind. And I think for parents and guardians, I think it's important to really emphasize that they've always been the one in charge of their child's healthcare decision. They're the experts of their child, and you're here to partner with them to make sure that they have all the information they need to make that good decision to vaccinate. But when you're doing this, make sure you lead with a presumptive recommendation, meaning saying something like, your child is due for 2 vaccines today, rather than saying, what do you think about your child getting these 2 vaccines? So just phrasing it a little differently, because again, you have that expertise and you want to make sure your patients and the families understand. Remind that vaccines protect them and their loved ones. I know this seems like a obvious thing, but just restating it to them, especially like the fact about their loved ones, their communities, if they're part of a faith-based community, making sure that they're protecting the community too, in addition to themselves, and not just from infection, but also the sequelae from infection, right? SSPE, from measles, post-COVID syndrome, in addition to hospitalizations and deaths. And then it can be helpful. And again, you'll have to tailor it to each of your patients and their personalities and their values. Explaining the potential costs of contracting a vaccine preventable disease can be helpful. And again, this can be not only the medical health costs, but also being out of work or missing school, things like that. So just some suggestions that you can try, and a starting point as you have your conversations with your patients. I also wanted to share with y'all, it was so interesting to see this. So this is about, and I know many of you are doing some public speaking or working with communities, or even as you're talking with patients, if you're finding some, that you need some additional suggestions or framing. So this came out of a partnership between AAP and the Frameworks Institute, who conducted a framing research. This included over 9,000 participants across the United States, very diverse demographically. They also conducted rural surveys. And so they had some suggestions about reframing the public conversation about child and adolescent vaccinations. So this was really interesting to me. One is shifting the focus from the individual to the collective. We are a very individualistic society here, but if you start out by talking about the benefits of vaccination for the common good, that will help put that first in their mind. And then, of course, you must connect that to shared benefits to an individual child. But starting with the common good helps to kind of like move folks away from that individualistic thinking. But also when you start talking about individuals, then suddenly it's like, well, also individual risks, parents having to make a decision for their individual child. And when they're balancing the benefits versus harms, they might start focusing more on those individual potential harms. So again, start with the collective good. The other thing is people might be like, well, those people aren't getting vaccinated, our vaccination rates are going down. And certainly that is something that we have to lift up. But talk about improving vaccination access as a preventive public health measure first, because many people are thinking that people aren't getting vaccinated because they don't want to, when in fact, many people aren't getting vaccinated because they're having trouble accessing vaccines, whether it's trouble accessing healthcare, transportation, insurance issues. So start with talking about this as a preventive public health measure and access as being the barrier to not getting vaccinated, not that someone doesn't want to get vaccinated. And then talk about the long-term child well-being that vaccines promote. So again, children become adults. And so think about the long-term rather than just saying like, oh, this disease, this vaccine protects against this disease, or, doing start statistics about like all the terrible things that could happen, or just simply saying vaccines are safe and effective. And then really focusing in on that vaccinations, that they are a partnership between parents and guardians, the child, the clinician, and the broader community. In addition to shifting the focus from the individual to the collective, it's also suggested that when you're talking about vaccines, shift the focus from, again, like I mentioned, vaccines fighting disease to the immune system preparing itself. This study showed that this was a more accepted framing of vaccinations. So, using computer or software update metaphors to explain how the immune system will improve its performance through vaccination. And this is because that if someone gets an infection after vaccination, if we're like, oh, the vaccine is going to help protect you, or it's going to help fight the infection, and they still get infected, they are going to think, oh, well, this means the vaccine failed. When in fact, it actually conferred some benefits. We know that if someone gets the flu vaccine and they still get the flu, it'll still decrease the severity of the symptoms, hospitalizations, deaths. And so just highlighting that this is priming your immune system and really helping it improve its performance. And then I love this one, use a literacy metaphor to explain how the immune system learns how to respond to viruses through vaccination. So compare vaccines to beginner texts. That's helping the child's immune system learn to read and comprehend. So just a different framing for all of this. But at the end of the day, there may still be some patients who decline, and that's okay. You still did good work. You put the seeds in their heads, and the important thing is just to continue those conversations. And I just want to point out that there are these new standalone immunization counseling billing codes. So if you do all that counseling in clinic and then the patient's like, I still don't want the vaccine, you can bill for the counseling, even if the vaccine was not administered. So just wanted to make sure that you all knew about this. So there are different ways to approach this. We know, again, this is challenging work. We know that you have time limitations and whatnot, but again, you are the most trusted source out there. The data is on your side, medical consensus, community consensus. We are also here to support you in all of that. And we've been trying our best to get that messaging out widely to the communities as well. So before I hand it over to Matt, I just wanted to let you know we have several resources. And again, we'll share these out so you have it. Please don't forget about our IDPH immunization website. There is a lot of information there, including our vaccine coverage dashboards. This is a good tool to use if you're talking about communities and that community good, to also talk about how you can protect your loved ones and whatnot by talking about the vaccination rates in your school or in your community. Don't forget we have our measles vaccination outbreak, or our measles outbreak dashboard. So if you want to get really granular, you could be like, look, here in our school, this is our risk of our school having an outbreak. So again, different tools for you. As I mentioned, the publicly funded the vaccine locator tool. I'll make sure you have links to the communication resources from AAP, Common Health Coalition, and then those new standalone immunization counseling billing codes.
Thank you, Matt. And again, thank you to all of you for hanging on so far. I am going to share first the poll results from our first poll, and let me know if folks can see it. But it looks like at least about 400 people answered, over 195, almost 200 felt very comfortable with concepts of shared clinical decision making, but several weren't, sure, no answer, or, a little uncomfortable. So I think we're hoping that some of the nuances around shared clinical decision making today were a little less ambiguous and more clear for those. Hopefully you can see that. We also, as I go through this, have another poll. Let's see, David, if you can initiate the second poll, that would be great. And while we have you here, we have 2 additional FastFact set up for the next 2 months. Again, we always do it on the 3rd Thursday of the month. It is to have public health content for clinicians that will really impact their clinical practice. Again, clinicians across the board, not necessarily just physicians. We do offer CME though. We are going to talk about regulations, and everyone's heard about citations, violations. So we will discuss in March implications to clinicians for public health regulations. And after that, what does public health mean for chronic disease? I mean, if you have patients that you care for with chronic disease, are there resources out there that we have that you might not be aware of? So we're going to share some tools and resources and some of the programs that we have involved in related to chronic disease. We have our upcoming webinars usually primed and ready to go about 2 to 3 months in advance for those who are interested in registering for the future. Next slide, please. All right, and if you do need to contact us in the Medical Services Division, there's a link below. You can also just Google it from Illinois Department of Public Health. And this is, again, if you really have specific clinical questions, these are for clinicians, not necessarily members of the public, for about what any reporting, regulation, any of this has implications for your clinical practice. Next slide, please. And of course, our siren system, for those who may not have heard of it, we do have a mass alert system. We put updates, guidance documents, all of that in our siren system. So if you're not a member or have not joined the siren system notification yet, please do so. We will share these slides again. We'll keep the list on for people who need to scan the QR code if they need, for a minute or two, and just so that they're able to sign up for our siren system and get updates. We have about 40 seconds left on our poll, and this is the QR code for CME. You can also use the forms section, answer the questions, and then you will be able to receive your CME credit. This is available till the 26th of February. So you have some time to be able to answer, and can answer it more than once if you don't get the questions right the first time. So no penalties for that. Next slide, please. All right, and with that, we'll open it up for additional questions that we will answer live. We have answered several questions in the chat. If you have additional questions, the time is now to put them in the chat, and we'll try to answer as many as possible live. All right, let's see if everyone can see the poll questions, the results on the poll. I'm not sure if folks can see it. I think the question is, what are the biggest challenges with regards to vaccination discussions that you're having, or just implementing vaccine related issues? And I think the biggest seems to be, the largest is patient misinformation, or false information that they are dealing with. And so also patient confusion about guidelines came up. I'm again hopeful that the content we have for you today will help address some of that confusion. And the third most popular option was patient insurance issues. So again, hoping that this provides a little bit of clarity that will help you in your clinical practice as we continue to navigate this really difficult landscape. This is going to be for all of us in public health, in healthcare. Vaccine preventable diseases are going to be the challenge of our lifetime. So thank you for being here today. And I'm going to close the poll and see if there are any additional questions in the chat.
There's one request to go back to the CE scan page. I'm not sure who has control of the deck. There we go.
All right. So we will post that. And there's another question on, can you put the QR code back up from Tony? If that's the CME QR code, we'll keep that open. And after that, we'll back it. And if you can then back into, after keeping this into maybe the Siren QR code. I'm not sure if that was what was intended. Yes, the CME is for physicians. What we have recommended, you will get a certificate of participation. You could take that to your licensing organization, and they accept a 1 CME equivalent from IDFPR as a potentially translatable credit to whatever licensing organization you have. Then you will be able to receive it through them. We just don't have direct agreements for CNEs or any other form of CEUs. Okay. All right. Okay, someone else wanted the QR code. Lena, I don't know if this is the QR code you meant. Is this for the CMEs? If you want, if we can also have, we also have the Siren QR code and one to register for our future fast facts. If you don't get these, again, when you get the slide decks, the QR codes are in the slide decks as well as the live links. So if you have time to access all of these, and our slides go through clearance. Once we go through clearance, we will share them with the group. I think one question I would like to answer live is was brought up about the risk around universal Hep B vaccination, and why is it that we are not as sensitive about considering risk. Our original take when we reviewed the data, and trust me, we did review the data about whether this is something that really is warranted. There is a time and point where a vaccine may not be required when we have truly eradicated a disease, think smallpox. When we get to that point, we truly say, no, there isn't a need for a vaccination. With hepatitis B, what we have observed on a population level, every time that there has been some level of risk-based assessment, we've not been able to achieve the same levels of overall hepatitis B going down, not just in children, but in adults, in the general population, as the impact we had with a universal birth dose. This is to capture, to prime again your immune system, to capture some of the risk of acquisition later on, regardless of the mother status. The risk-based currently is entirely on the mother status, but children can acquire Hep B outside of the context of their maternal risk. And that's why we wanted to emphasize that this birth dose is not just about maternal risk, it is about the child and then the future adult having risks that would then warrant really some level of protection. And when it was the most effective time to put that, and that's at the birth dose. So there have been different times and point where it hasn't always been the birth dose. If you, Dr. Sir's slide will explore that especially in the appendix, that there were times when universal blood dose was a little delayed and we didn't achieve the same level of drop in hepatitis B incidence as with this. I'll open it up to Dr. Sir to add any additional context to that.
I was just going to say I agree, and I can try to go back to that slide. Sorry if I'm making anyone motion sick. I don't know how to do this any better. But you can see the different time points. And over the years, the ACIP refined that guidance around the birth dose and made it universal because they were still seeing that there are cases happening. And as Dr. Barr said, before the universal birth dose was in place, certainly there were many children who were acquiring hepatitis B outside of that perinatal period. And then, as I mentioned, for hepatitis A, kids become adults. And Dr. Barnes also mentioned this, we want to make sure we're protecting them. We know that adolescents have, the highest rates here in Illinois of hepatitis B. And so the risk increases as they become older too. And so just want to make sure that they are protected. The other thing to keep in mind, and again, some of the appendix slides will explain this, is we know that up to 18% of pregnant people don't get their screening. And 50% of people in the United States have hepatitis B and don't realize it. So again, many different factors, but again, this very real world where the ACIP saw the impact of kind of it suggested that you do universal, and then finally they decided it needed to be everyone just needed to get it because there was implementation challenges with actually screening pregnant individuals, et cetera. So yeah, but great questions and things that we want to continue the conversation about.
And there's one more question in the chat that's important to address about whether a child's immune system is mature enough to receive a vaccine, and if receiving a vaccine would in fact cause any stimulation of the immune system at that age through vaccines would impact their have adverse effects. And again, it's really important. That's the question that everyone's struggling with. And I will start and have Dr. Sir finish. So I think there is a caution. There are vaccines we do not give under the age of 6 months. There are vaccines that they've been studied to make sure they are given at a time that it works the best for the child's immune system. And there is data on how hepatitis B impacts specifically the growing immune system. And so there is thankfully, I think, good science there. And Dr. Sir, anything on that?
Yeah, and I think the other thing is these vaccines have been around for several decades. We've been doing this birth dose. I mean, one thing just to consider, sorry about my voice, is that for the kids who are born and they're under that 2,000 grams of birth weight, the recommendation is to wait until hospital discharge or until they're 1 month old, just so that their immune system can be primed. But I think the other thing is it's really important that, taking hepatitis B as an example, they need to finish out that series. And we need them to finish out the vaccine series to make sure that they get the full immune response that they need. But there have not been any concerns in terms of the data out there in the studies that doing this vaccine at such an early age will impact immune responses later on with regards to the hepatitis B vaccine.
That's all we have time for. So again, appreciate everyone's attention to this issue, regardless of how you feel about this. It's important that we just learn from each other. And so appreciate everyone, and hopefully we'll see you again next month. Take care. Bye, everyone.